Good evening. My name is Gina Hechanova Alampay, and I'd like to thank the psychiatric. Good evening. My name is Gina Hechanova Alampay, and I'd like to thank the Philippine Psychiatric Association for the invitation to speak to you today about community-based rehabilitation in the Philippines. I'd like to share a little bit our experiences from the USAID Renew Health project. Just a little bit about us. So the goal of this project is so that by the end of the 5-year period, more communities will be able to provide evidence-based approaches so that our Filipino persons who use drugs can access this without fear or prejudice. And so our theory of change is if we can enhance the capacities of communities and agencies providing drug recovery services, if we can create and scale up evidence-based interventions and foster an enabling policy environment, then our PWOODs will have access to treatment, thereby reducing drug dependence. So I'd like to talk to you a little bit about the national client flow and national data on drug use, our own study on the profile of community-based drug rehab clients, and some initial evidence on community-based treatments. So first, the DDB household survey of 2019 reveals that about 2.05% of Filipinos are current users, while 5.8% have used drugs at least once in their lifetime. Age of use is 22 years, but there appears to be a gateway phenomenon with cigarettes being used first at an average of 17, and then alcohol at 20 years old. The DDB study also suggests that mostly drug use is influenced by friends and curiosity. However, you also have people who use drugs because they're stressed to cope with problems, both personal or work. Drug of choice in the Philippines is marijuana and shabu. And the DDB board regulation on 7 of 2019 suggests that this should be the client flow for drug treatment. So it begins with screening. And here the tools that are being recommended is the WHO Assist as well as SRQ, which screens for mental health risk. And based on such screening, then low-risk clients can be referred to general interventions. Moderate-risk clients can be referred to community-based treatment. Those with comorbidities will be referred to mental health professionals or medical professionals, whereas those who are high risk and court mandated need to go through drug dependency examination by a DOH accredited physician. Depending on the results of the DDE, clients can either be referred to community-based programs, facility-based outpatient programs, facility-based inpatient programs, or specialized treatment. Now, when we began our project in 2019, one of the first things that we wanted to do is to understand what kinds of programs might be most useful. So in 2020, we did a study of about 962 PWOODs in various local government units, and we found this profile. So generally male, uh, low educational attainment, so high school and grade school were majority of users only had high school and grade school education. In our profile, majority were voluntary clients. And here you'll see by risk level, only 14% actually considered high risk. Uh, Majority, 86%, were either low or moderate risk. You'll also see that in terms of smoking, there's slightly higher percentage of high risk smokers as well as high risk alcohol users. We also saw a relationship between drug use and mental health. And of course, you're psychiatrists, so you know that. As you see here, in general, about 1 in 5 drug users will also have mental health uh, problems. And this actually, the numbers, the percentage rises according to risk level. To understand better what kinds of treatment might be most important, we did structure equation modeling to understand the direct and indirect predictors of use. And here you'll see that drug dependence is predicted by severity of drug use. And in turn, severity of drug use is predicted by cigarette and alcohol use, mental health problems, and recovery skills. So here, recovery skills means the extent to which people are aware of why they use, what their triggers are, their ability to manage their triggers, the ability to manage their cravings, as well as refusal skills. You also see on the left-hand most of your screen that quality of life is an indirect predictor. Well, those with better quality of life um, are less likely to have mental health problems, less likely to use cigarette and alcohol, and those with better life skills are also less likely to have mental health problems and more likely to have recovery skills. We also saw differences in the predictors by risk level. So you'll see here that moderate risk and high risk clients had significantly higher SUD symptoms, frequency of smoking alcohol, and mental health risk compared to low risk clients. At the same time, high risk clients had significantly lower recovery skills, life skills, and psychological well being. We actually also saw differences between voluntary clients and what we call plea bargainers, or those who either have come from prison or from jails because of drug cases. And here you'll see that actually it's the voluntary clients who have higher use of smoking and alcohol, which is understandable because they are in the communities as opposed to plea bargainers who are coming from the jail system. However, plea bargainers reported lower quality of life compared to voluntary clients. So, what does this all mean? What are some implications? So, one, the results validate the new client flow that suggests different interventions by risk level. It also suggests what type of treatment might be most useful. So, for example, life skills and recovery skills appear to be important predictors and should be part of treatment. Family support is also an important predictor, and therefore the need to include the family in programs. Mental health risk was a strong predictor, suggesting the importance of an integrated approach to substance use and mental health. And that drug treatment should not only consider just illegal drugs, but also should focus on other substances. You also see how quality of life as a predictor suggests we need to view CBDR more than just treatment, and providing wraparound family community supports and aftercare and reintegration services. So if we use the data, what might ideal interventions be like? For low risk users, perhaps a program that focuses on holistic health, well-being and stress management, and preventive education. For moderate risk clients, perhaps family and community support, family interventions, and recovery life skills. And for moderate risk plea bargainers, um, recovery skills, family intervention, family and community support, as well as aftercare and reintegration. When we began the USAID project, we wanted to find out what were the local government using and which ones could actually be scaled up. So we brought together an expert panel of representatives from different government agencies to review the existing programs being used by local government units. And the panel identified a program that was scalable was KKDK by the Psychological Association of the Philippines. It also identified a gap in the lack of low risk programs for low risk users. So a little bit about the KKDK program. It stands for Katatagan, Kalusugan at Damayan ng Komunidad. It's a 15-module program, and the first part focuses on drug recovery skills. Next part focuses on life skills, and it also has family modules. Its theoretical foundations are MI, or motivational interviewing, cognitive behavioral therapy, mindfulness, and family systems. There have been 3 studies published so far on the KKDK program. And in all 3 studies, participants reported significant increases in drug recovery skills, life skills, and well-being. 2 studies reported increased family support and a decrease in SUD symptoms. Beyond the KKDK program for voluntary clients, the KKDK team also created a more intensive program for plea bargainers because the court requirement is 6 months. So in this program, it had still drug recovery skills, life skills, and family modules, but in a more intensified way, because in consideration of the background of those who have been incarcerated because of drug use, which includes perhaps drugs in their environment, crime, and the possibility of family separation and conflict. There's been one study that has been published so far on this, and it used a quasi-experimental design with a pre and post test survey with a treatment and a weight control group. Okay. So there were a group that had no treatment, a group that underwent the program in the community, and a group that underwent the program as pre-release, meaning they were still in detention or in jail. So as you see here, those who went through the program had improved recovery and life skills compared to those who did not go through the treatment. Those who received treatment also had lower SUD symptoms compared to those who did not go through the treatment. Completion rates were higher, of course, for pre-release programs as opposed to those who went through the program in the community. In response to the request for a program for minors, the KKDK program was reconceptualized for kids by a team of social workers, developmental psychologists, and community facilitators. The program still consists of the following active ingredients: knowledge of drugs, recovery skills, life skills. But the design is such that it is a family intervention, meaning it's the child and a family member who goes through the entire program. So there are parallel session for parents and parallel session for children, and there are sessions, times during the session where they are brought together. So there's been one evaluation of the program so far with a control group and a treatment group and data from parents. So those who attended the program reported significant improvements in life skills, recovery skills, parent-child relationship, and quality of life, and a significant decrease in SUD. However, those who did not go through the program had no improvements in any of these except in recovery skills. And we were able to figure out that it was because there was some vicarious learning going on. So some of the participants would actually share to the non-participants some of their learnings. In terms of parent data, parents, the pre and post tests of parents indicated significant improvements in parent-child relationship and quality of life. So these KKDK programs have been recognized by the Dangerous Drug Board as models for LGUs in community-based drug rehabilitation programs. However, we recognize that there is a need for more rigorous evaluation. For example, using randomized control trials to establish stronger evidence, or for example, using longitudinal studies. We also recognize that it's also important that even when there are structured interventions, there also needs to have an orientation of client-centeredness, meaning rather than a one-size-fits-all, some clients may need some modules but not others. We also recognize the importance of cultural adaptation when appropriate. A large part of the success of community-based programs is really the community facilitators delivering them. So it's very important to enhance their capacities, even as they may not be real health professionals. It is possible with rigorous training and coaching and supervision to train paraprofessionals to deliver these interventions. We also recognize that a challenge is how do we institutionalize community-based drug rehabilitation as a means for voluntary drug demand reduction and not just as a response to a drug war. But we also found that there are certain barriers to help seeking that may impede a client from actually even going to treatment. And our formative study in 2020 suggested that for users, the majority are pre-contemplation. They don't know that they need help or what the effects of drugs are. But there's also a lot of not wanting to get help because of shame, because they are belittled, or they have no information, or because there's a strong influence of their barkada, and because they have no alternative ways to cope with their problems. On the other hand, a barrier to help seeking is that families don't think the user needs help, or they think they can handle the problems on their own. Among service providers, and by service providers here, I mean they can either be community facilitators, faith based volunteers, or even health professionals. We found that the top three myths that may get in the way of treatment are the myth that all drug users are addicts, become addicts, or two, that addiction is a sign of moral character weakness, and three, that all an addict needs to do is to recover is the will to stop. So these are common beliefs and misconceptions that need to be addressed if we are really to provide a more appropriate way of helping our PWOODs. So we believe that it's important to increase help seeking and diminish the stigma and discrimination through social behavior change communication. Because of the drug war, the emphasis has really been drug use as a crime. And so we really need to shift the discourse so that drug use will be looked at as a health issue. But in order to do that, it also means that we may need to embed, for example, the delivery, screening, and brief intervention in primary care, and to look at an integrated delivery system for both drug treatment and substance use and mental health treatment. Having said that, we think that community-based drug rehabilitation, which has taken root in other countries, is an important aspect of healthcare delivery, especially for our persons who use drugs. And it is something that we hope can continue to expand, to improve. And we look forward to having this as part of community mental health services, perhaps in the future, and something that is integrated, not just in local government units, but in the workplace and in schools as well. Thank you all for your time. And I hope I was able to share some new insights on community based drug rehabilitation.